In this unit, we will look at hemodynamic disorders. These are disorders due to interruptions in the normal blood flow. First, we will look at a thrombosis. The definition of a thrombosis: it is a mass of platelets, red blood cells, white blood cells, and fibrin. One thing to note about a thrombosis: many people think of it as a clot. A thrombosis is not a clot. There are several reasons and differences between a thrombosis and a clot. First, a thrombosis never develops outside of a blood vessel. A thrombosis develops from and maintains a point of attachment to the blood vessel wall. And lastly, the blood components within a thrombosis are very highly organized compared to that in a clot. How does a thrombosis start? They typically start at a spot where platelets begin to adhere to a vascular wall. This is usually a point where the endothelium is irregular or where the endothelium has been removed to expose underlying collagen. Once a few platelets begin to attach, others soon follow. Once a thrombosis starts, how does it continue? How a thrombosis proceeds depends on the movement of blood within the vessel, and this will differ between arteries and veins. The first is an artery where blood flow is rapid and regular. Here, the formation of fibrin will be limited because the regular flow of the blood will carry away thrombin and other clotting factors. As a result, only very small amounts of fibrin will form. The fibrin that does form acts to strengthen the mass of platelets at the site of attachment. However, it still is not allowed to accumulate. Also in these types of thrombi, you see very few red blood cells or white blood cells. This type of thrombus formation is what is also seen that develops in cardiac valves or in the heart chambers. In arteries and veins with turbulent blood flow, fibrin tends to build up around the initial site of attachment. This will trap a lot more red and white blood cells. The turbulent flow helps to wash even more platelets over this mass. As they become activated, attach and activated, they will cause more fibrin production. The mass will begin to enlarge and exhibit alternating layers of fibrin, cells, and platelets. These layers are known as layers of Zahn. This picture illustrates a large thrombosis in this type of a vessel. You can see the lines of Zahn. These darker lines represent the layers of fibrin, and in between the fibrin you will see the cells and the platelets. In veins with slow blood flow, enough clotting factors are able to accumulate to produce large amounts of fibrin. You will begin to see a large red cap of coagulated blood. This will form downstream from the initial site of attachment. In general, atrial thrombi tend to be smaller and venous thrombi tend to be much larger. This picture illustrates the difference between the two. Top picture shows a thrombus that develops in an artery, and the lower one illustrates a thrombus that can develop in the venous system. Notice this extended long red cap that can form in the venous system. There are various factors that can predispose a person to developing a thrombosis. There are three factors that we will look at. The first factor is endothelial damage. When the lining of the blood vessels become damaged, it then favors the attachment of platelets. This will start the whole process of thrombosis formation. The same thing can happen if either the endocardium or the myocardium of the heart becomes damaged. What can cause this damage? In arterial system, there are two main causes of endothelial damage. The first is hemodynamic stress. Hemodynamic stress refers to the normal wear and tear on the endothelium as blood is driven through the arteries under pressure. The arteries expand and contract about 70 times per minute as blood is pushed through them. If something elevates the pressure, it will then increase the stress that the vessels are under, and the more stress they are under, they will then have an increased likelihood of damage occurring. An example of a scenario that would cause hemodynamic stress would be hypertension or high blood pressure. Another cause of endothelial damage in the arterial system is arteriosclerosis, also known as hardening of the arteries. This can result in damage to the lining of the blood vessels, leading to the development of a thrombosis. In the venous system, there are several factors that can damage the endothelial lining. The first is inflammation. For example, in appendicitis, a person with appendicitis has an increased risk of thrombosis development in their mesenteric veins. Tumors can also result in damage. Renal thrombosis is common in people with renal carcinoma. Leg vein thrombosis is commonly seen in pancreatic tumors. There is also iatrogenic thrombosis. Iatrogenic means due to some type of intervention or due to a healthcare professional that brings about or causes the problem. Here, an iatrogenic thrombosis might be due to therapeutic intervention. For example, this might be after a long-term IV fluid administration. In both systems, cause of damage to the endothelial lining could be due to trauma. Trauma would be things such as after an auto accident, fractures, falls, or occurring after surgery. A second factor that can predispose a person to developing a thrombosis would be flow abnormalities. This refers to changes in the normal pattern of blood flow. One change in the normal pattern might be due to a reduction of the flow rate. In arteries, when the flow rate is decreased, platelets will tend to accumulate closest to the vessel wall. As they accumulate, this increases their chances of adhering to each other and, as a result, will increase the likelihood of a thrombosis beginning to occur. What causes a decrease in flow in the arteries? Might be cardiac damage. When the heart is damaged, it will have a reduced ability to pump the blood, and this will slow down the blood flow. It might also be due to increased viscosity. Viscosity refers to the thickness of blood. Thicker blood meets more resistance and, as a result, flows much slower than normal blood. Due to this increase in viscosity, this will slow down the blood flow. What can cause an increase in viscosity? Most commonly, it is due to an increased number of formed elements. For example, in leukemia, you would see an increased number of white blood cells. It could also be the result of dehydration. A person who is dehydrated has less plasma volume or water volume in the blood. This will increase the relative number of cells compared to the amount of water and make the blood more viscous. In the venous system, flow abnormalities may also be due to an increase in viscosity, or they may be due to physical inactivity. Physical inactivity will slow the normal rate of circulation, and this is mainly due to a decreased demand by the muscles. Less activity also results in less muscle contractions. Our blood, in order to get it back to the heart, relies on muscle contractions. If our muscles are inactive, less blood is going to be flowing through the veins. This is important especially in the leg veins, like I said, because they rely on our skeletal muscles to help with the blood flow. Varicose veins are another factor that can reduce the blood flow. Varicose veins are regions of the vein wall that become weakened and are unable to maintain their normal muscular tone. This weakened wall will sag away from the blood flow in the lumina of the vessel and forms irregular bulges. Venous pressure will then drop and blood flow will decrease. Also, the endothelial lining of varicose veins are more irregular than normal veins, and this can lead to the development of a thrombosis. This picture illustrates how our muscles help with blood flow. When our muscles contract, they will squeeze and compress our blood vessels, which will force the blood back to the heart. If our muscles are inactive, this mechanism is not set into motion, and you will have decreased venous return or decreased blood flow in the venous system. Another flow abnormality might be turbulence in the blood. This increases platelets' contact with the linings of our blood vessels as well with the lining of the heart. Turbulence reduces the smoothness of the vessel wall, or it can also restrict the passage of blood through the vessels. What can cause this? Tumors. Many times tumors apply external pressure to the vessel wall. Another cause could be weakness in the vessel wall. This can result in bulging, like we talked about with the varicose veins, and it can also be seen in arteries. This is known as an aneurysm. This picture illustrates the effect of a tumor. When a tumor presses on the vessel wall, it will compress the wall, resulting in flow abnormalities. This is illustrating a weakened vessel wall causing a bulge, which will cause blood to accumulate in this area, also changing the pattern of flow. The third factor that can predispose a person to a thrombosis is blood hypercoagulation. This is due to excessive production of procoagulants or due to a deficiency in anticoagulant factors. This might be the result of various diseases, burns, kidney disease, heart failure, metastatic tumor growth, or chronic use of oral contraceptives, especially estrogen. It is important to note that rarely is a thrombosis due to only one factor. Usually several of these factors work together in the development of a thrombosis. We've looked at how a thrombosis forms. Now, what are some of the consequences of a thrombosis? One consequence might be resolution. It resolves itself. The anticoagulation system in this scenario would take over and overcome the factors that favored the formation of a thrombus to begin with. A thrombus may start but does not continue to develop. Some that do form may then be dissolved or reduced in size so that they have no effect on the body. Moderate exercise helps to increase the activity of our fibrinolytic system, and as a result, this will increase your ability to resolve a thrombus if one does develop. Another consequence is that the thrombus may begin to organize. This occurs when a thrombus undergoes phagocytic digestion. You get replacement of platelets and fibrin with fibrous connective tissue, and then endothelium will form over this. The thrombus ends up being enclosed in a wall. As it undergoes organization, channels may begin to form through the thrombus, allowing blood to flow through. And this is what we're seeing here in this picture. This would be a whole thrombus. This is not individual pieces. It would all be attached to the vessel. But over time, it has developed these channels that are allowing the blood to flow through. Another consequence would be propagation. Once a thrombus forms, it enlarges and extends itself further down the vessel. The surface of the thrombus acts as a site for further platelet attachment. This can also occur in areas of very turbulent flow, such as around valves or branches in blood vessels. So we see it is propagating itself. It is becoming larger. Very common where you have branching in your blood vessels. Another consequence is infarction. Infarction means you can get the formation of an area of necrosis, also known as an infarct, due to oxygen deficiency or ischemia. Ischemia is an area of damage that is caused by reduced blood flow. Hypoxia refers to a decrease in the amount of oxygen that results from a reduced blood flow or a lack of blood flow. So here we can see a thrombosis has occluded the vessel, it's prevented the blood flow. This is the area of the infarct. You can end up seeing damage as a result of this reduced blood flow and lack of oxygen delivery. Looking further at an infarction, ischemia is caused as the result of a thrombus that narrows or completely blocks the lumen of a blood vessel. This is very serious if it occurs in an artery. Remember that arteries are responsible for supplying oxygen as well as nutrients. Arteries also remove waste products. You will get tissue damage due to hypoxia and the lack of nutrients as well as the buildup of waste products in the tissue. Anoxia refers to the complete lack of oxygen. If this occurs in the brain, you will get an area of necrosis called an infarct. The necrotic area will liquefy due to the inflammatory response, and you will get this buildup of fluid at the site of the infarct. The cellular debris will be reabsorbed, but the fluid-filled cavity remains. This cavity does not fill with scar tissue because fibrosis is limited in the brain. Instead, it tends to fill with neuroglial cells. In other tissues, the result of anoxia will result in a dry necrotic area. You will see an inflammatory response that breaks down necrosis and replaces it with scar tissue. What are some causes of the infarctions? In an arterial system, it is usually due to a thrombosis, but another cause might be external pressure on the artery due to a tumor, or it could be the result of vascular disease, such as arterial sclerosis. Vascular disease can cause thickening of the vessel wall. When the vessel wall thickens, this will decrease the size of the lumen. This is the most serious types of arterial infarctions occur in the brain and in the heart. In the venous system, infarction is less common. The reason being is that one area is usually drained by several vessels known as collaterals. If one of these vessels become obstructed, blood can drain through one of the other collaterals. So we see here we have an obstruction that should block this area, but because of the collaterals, there is another means for blood to get to that area. One cause of infarction in the venous system would be herniation. This is when a loop of the intestines is twisted or forced out of the abdominal cavity. This causes pressure at the point of the twisting, and this can compress the veins that drain the intestines, and as a result, an infarction may result. What are some factors that can affect an infarction? The outcome of an infarction depends on 4 factors. 1, it depends on the tissue's vulnerability to hypoxia. Nervous tissue is very vulnerable. Brief periods of hypoxia in the brain can be fatal. The heart, or the myocardium, is the next vulnerable tissue. It takes longer periods of hypoxia to cause damage to the myocardium. Fibroblasts are least sensitive because they act in the repair process and fill in areas with scar tissue. Another factor that can affect an infarction is the pattern of vascular supply. If there is an alternate route, such as an anastomosis, by which the blood can reach the tissue, there will be less of an effect with the infarction. The more anastomoses there are, the more likely that tissue is to resist the effects of obstruction. Another factor is the oxygen delivery capacity of the blood. An infarct will develop faster in a person whose oxygen delivery system is already reduced. This is seen in people who are anemic and people with weakened hearts. The tissues are already partially hypoxic, so it will take less of an occlusion in order to cause damage. And fourthly, the rate of development of an occlusion depends on the time needed for collateral vessels to form. Collaterals will form in an attempt to reverse the tissue's oxygen deprivation. This occurs slowly, and if the occlusion occurs rapidly, Collaterals may not have any effect because they do not have time to develop. Another structure to look at is an embolism. An embolism is an abnormal mass that moves with the bloodstream. Interruption of blood flow by an embolism is a common cause of infarction. One type of embolism is a thromboembolism. This is formed when a thrombus or part of a thrombus breaks away from the vascular wall and is carried away in the blood. If it is from an artery or the cardiac surface, they are usually small and made up of fused particles in fibrin. If they come from the venous system, they are usually larger due to the large red cap of coagulated blood. What can cause this detachment? One is the normal variations in blood flow. It might be due to temporary pressure changes. This could be brought about due to posture changes or due to exercise. It might be due to the resumption of normal activity after prolonged inactivity. It could be due to surgery or therapeutic manipulations. Or it may be due to the action of the fibrinolytic system. Remember, the fibrinolytic system is what would degrade or try to break down and prevent these thrombi from developing. This causes degradation of the fibrin, which can help loosen the wall, and small pieces of the thrombus may break away. The result is that these emboli can lodge in vessels downstream, causing occlusion and possible infarction. Arterial thromboembolisms is an embolism in an artery. Any embolism in an artery will be carried away through successively smaller vessels until it becomes trapped in one whose diameter is too small to allow it to pass. Remember how blood flows. As it leaves the heart, arteries are vessels that carry blood away from the heart. So you go from very large vessels associated with the heart to smaller arteries, to arterioles, and eventually to capillaries. So you are going through successively smaller vessels. When it becomes trapped, it will result in an occlusion and possibly an infarct. The size of the infarct depends on the size of the blocked vessel and the degree of anastomosis in the affected tissue. Usually, arterial thromboembolism arise from cardiac thrombi or the site of an aneurysm. The resulting emboli are likely to lodge in the kidney, spleen, brain, or lower limbs, because these areas receive a large part of the cardiac output. Venous thromboembolisms. Here in the venous system, blood flows through increasingly larger vessels until they reach the heart. So we would start with a venule to a vein, to larger veins, and eventually back to the heart. After the heart, they are pumped into the pulmonary arterial system. So as a result, they are not likely to occlude a vessel on their way to the heart, but they can occlude a vessel afterwards. An infarction with a venous thromboembolism can result, but its effects are usually minimized. This is due to clot retraction. This refers to the retraction of fibrin. This will reduce the size of the embolus and allow adequate blood to pass. It is also minimized due to the double blood supply to the lung. It gets oxygen and nutrients from blood from the heart and the brachial arteries. So if one becomes cut off, it will still have another. The effects are also minimized due to the fibrinolytic system. The fibrinolytic system functions to a much greater degree in the lungs. This helps to loosen and dissolve emboli in the pulmonary vessels. Most thromboemboli are small and end up occluding minor vessels, resulting in very little effect. Let's look a little bit more at the actions of the lung. The lungs act as a filter to help remove thromboemboli before they reach the systemic circulation. The lung is very adept to handle them due to the above factors that we just discussed. However, if there are too many emboli, or if they are too large, even the lung may have a problem. You can see loss of pulmonary function. This can result in an increase in blood pressure, causing vessel damage, which can result in hemorrhaging into the pulmonary tissues. If enough arteries are occluded, the back pressure can end up weakening the heart and cause heart failure. And this is known as right heart failure, which we will be talking about in an upcoming chapter. Most pulmonary emboli originate from the leg veins. Very large emboli from the leg veins can become lodged in the right cardiac valve or in the pulmonary arteries. This will shut off blood flow to the lungs and to the left heart. As a result, cardiac output falls and death can result. Other emboli from the veins end up in the liver. These are from veins that drain the intestines, the stomach, the spleen, and the abdominal viscera. The liver also has a dual blood supply, so an infarction usually does not result. This picture shows the typical pathway for thromboembolism. They develop here in the leg veins, they come up through the heart and end up becoming lodged in the lungs, or they can end up in the liver. Therapy for intravascular thrombosis and for thromboemboli, one would be anticoagulants. Anticoagulants act by blocking or interfering with blood coagulation. An example of an anticoagulant would be heparin or warfarin. This blocks thrombin and fibrin formation. Another therapy is antiplatelet therapy. This acts to interfere with the platelets' role in coagulation. It limits their ability to aggregate and then to activate. Aspirin is an example of antiplatelet therapy. There are also enzymes that activate plasminogen to form plasmin. This will promote the action of the fibrinolytic system instead of limiting coagulation. An example of an enzyme would be streptokinase. This is a plasminogen activator. This flowchart shows how these work. Anticoagulants, such as heparin, this will block or prevent the coagulation cascade, resulting in less fibrin formation. Antiplatelet therapy, such as aspirin, will prevent platelet aggregation, so you would have reduced risk of a thrombus developing. And then fibrinolytic therapy, this would be enzymes that will promote the formation of plasmin. Plasmin will help to reduce the size of a thrombus. Other types of embolism. There are fat emboli. These are formed when fat-rich yellow bone marrow gains access to the blood. These are usually small, but they can form in large numbers. They arise as the result of fractures in your long bones, such as your femur or your tibia. Because they are small, they tend to lodge in small arterioles and capillaries. If they get to the lung, you can see mild difficulty in breathing up to complete respiratory failure, again depending on the size and the number of emboli that are released. Because they are small and made of fat, they are compressible and can pass through the pulmonary circulation into the systemic vessels. Oftentimes they end up going to the skin and cause a diffuse rash of petechial hemorrhages. The major problem is that they cannot pass through small cerebral vessels. They will cause vessel damage and petechial hemorrhages in the brain. You can also get infarcts forming, resulting in coma and death. There are also air emboli. This is when gases enter the blood, and they can act as an emboli. Gases enter the blood when veins are open to the air. This might occur during surgery, the result of a fractured rib, knife wounds to the thorax, neck surgery, laceration of the jugular veins, or improper administration of IV fluids. These will only be of significance if they are very large. They need to be at least 100 milliliters in size to be of any significance. However, they can be potentially fatal if they are 300 milliliters or larger. The principal effect of an air emboli is to the heart. The heart is designed to pump fluids that cannot be compressed. If air gets into the ventricle will contract and increase pressure. This normally would push the blood out of the ventricle, but air ends up being compressed as the ventricle contracts, and it will not move out of the heart. Then, when the chamber relaxes, this air expands. Because the air has expanded and filled the chamber, less blood is going to be pumped, and cardiac output will fall. The churning of the air and blood in the ventricle will also result in the damage of platelets. This may then result in the development of a thrombosis. One can counter the effects of air emboli by placing the body in a position such that the right ventricle is elevated. This will cause the air to rise and allow the blood to fill the ventricle. As the blood flows under the air embolus, small quantities of air will be harmlessly carried away. There is a condition known as the bends. The bends are due to an abrupt reduction in atmospheric pressure. When this happens, nitrogen gas from the tissues leaves the tissues and enters into the blood. This causes the production of nitrogen gas emboli. These can result in joint pain and can result in brain damage. The bends are seen very often in underwater divers. They can be seen in air travelers and tunnel workers, especially those who breathe compressed air. There are also amniotic fluid embolism. This is a rare complication of childbirth. What actually ends up occluding the vessels are the infant's cells, not the fluid, that have been shed into the amniotic fluid. During delivery, clumps of these cells enter into the maternal circulation via tears in the placental membrane, tears in the uterus, or the cervical veins. These can be carried to the lungs where they become trapped in the small vessels. You can see a difficulty in breathing resulting from these. Then lastly, there are foreign body embolisms. For example, this would be due to a bullet fragment. The site where it is trapped depends on where the embolus or the fragment enters into the circulation.